Good morning, everyone. We are going to present our case study presentation of COVID-19.
30 years old man with a past medical history of alpha-thalassemia who came to the emergency department or ED and with generalized
Complications
weakness,
of
fever,
COVID-19.
chills,
Although
productive
most
cough
people
with
with
scan, yellow
COVID-19 have mild to
sputum,
moderate symptoms, the
myalgia,
disease can cause severe
arthralgia for
medical
10 days.
complications and
And
lead
this
to death in
patient
some
endorsed a
people.
lack of
Older
appetite
adults or
and
people with existing
on
medical
his
conditions
episode
are
of
at greater risk
non-values,
of becoming seriously
balicious,
ill with
vomiting with
COVID-19.
epigastric pain and dysphoria.
Complications can
At
include
this
pneumonia and trouble
presentation, the patient
breathing,
denied
organ failure in several
chest
organs,
chest
heart
pain,
problems, a severe lung condition that
shortness of
causes
breath,
a low amount of oxygen
palpitation,
to go
or
through your
diarrhea.
bloodstream to your organs,
And
or
this
acute
patient had not
respiratory
traveled
distress
outside of
syndrome,
the United States
blood clots,
and had
acute
no known
kidney injury,
allergies.
and additional viral and bacterial
And
infection.
his physical examination was remarkable for scattered bronchi bilaterally, and this patient was not found to be in any distress, and his heart sounds were normal. The patient was alert and oriented to time, place, and person, and his cranial nerves 2 to 7 were grossly intact. Sensation was intact to touch, and strength was 5/5 throughout the upper and lower extremities bilaterally. In the emergency department, his vital signs included a temperature of 100.7 degrees Celsius, and his blood pressure was 105/54. Arterial blood pressure of 71 and heart rate of 70 beats per minute. The respiratory rate of 16 minutes and saturation of 97% on room air. And his laboratory result were as follow: white blood count 3.9 rather, and the normal is 5.2 to 12 to 4, and the hemoglobin is 13.9 gram per deciliter, and the normal is 12.18. An echocardiogram or EKG shown normal left ventricle systolic function and the left ventricle ejection fraction, estimated by two-dimensional echocardiogram at 60% to 65%. The blood, urine, and sputum cultures were all negative. The chest X-ray shown bilateral ground glass opacities in the lower lobes. In this figure 1 to 2, an acid-fast bacillus smear was negative. This patient was placed on airborne, droplet, and contact isolation because of the high suspicions of coronavirus infection. And this patient was empirically started on hydrochloroquine and azithromycin, and his pulmonologist was consulted, and his screening test came out to be positive for COVID-19. The COVID-19 Task Force, New York City Department of Health, and CDC COVID-19 protocol were full effect. The plan was made to discharge the patient on his quarantine for 14 days to limit transmission to the others. Pathophysiology of COVID-19. COVID-19 is a respiratory illness, and it caused by a type of virus called coronavirus. This novel coronavirus first discovered in China. COVID-19 disease caused by SARS-CoV-2 infection. a new type of coronavirus that appeared in 2019 in China, the first known coronavirus pandemic in modern times. Although SARS-CoV-2 infection was initially described as an atypical pneumonia, extrapulmonary manifestations were quickly identified, particularly in patients with comorbidities. And the most of the pathophysiology and manifestation of this virus occur because its entry point is the angiotensin converting enzyme 2 element of the renin-angiotensin system. In addition, the pathophysiological basis that determine the pre-existent condition like cardiovascular disease, diabetes or obesity predispose. And these are the risk factor for COVID-19 appear to include: first, close contact with someone who has COVID-19, especially someone with symptoms. Second, being cough or sneeze on by an uninfected person. And lastly, being near an infected person when in an indoor space with poor airflow.
Complications of COVID-19. Although most people with COVID-19 have mild to moderate symptoms, the disease can cause severe medical complications and lead to death in some people. Older adults or people with existing medical conditions are at greater risk of becoming seriously ill with COVID-19. Complications can include pneumonia and trouble breathing, organ failure in several organs, heart problems, a severe lung condition that causes a low amount of oxygen to go through your bloodstream to your organs, or acute respiratory distress syndrome, blood clots, acute kidney injury, and additional viral and bacterial infection. Subjective information. For the subjective information of the patient reported that he is experiencing with generalized weakness, fever, chills, productive cough with scant yellow sputum, myalgia, and arthralgia for 10 days. The patient endorsed a lack of appetite and an episode of non-bilious vomiting with epigastric pain and dysuria. The patient denied chest pain, shortness of breath, palpitations, or diarrhea. The patient had not traveled outside of the United States and had no known allergies. Objective information. For the patient information, the patient is a 30-year-old man with past medical history of alpha thalassemia. For the lab test of the patient, physical examination was remarkable for scattered bronchi bilaterally. The patient was not found to be in any distress. An echocardiogram or EKG showed normal left ventricular systolic function. Left ventricular ejection fraction estimated by two-dimensional EKG at 60% to 65%. Blood, urine, and sputum cultures were all negative. Chest X-ray showed bilateral ground glass opacities in the lower lobes. The patient was placed on airborne droplet and contact isolation because of the high suspicion of coronavirus infection.
So next we have the assessment. Under the assessment, we have the problem list. The patient was empirically started on hydroxychloroquine and azithromycin. So we presented an evidence which can support the problem. So there is currently insufficient evidence to recommend treatment with macrolide antibiotics for COVID-19, alone or combined with hydroxychloroquine outside of research. There remains potential for harm. Clinicians may wish to use macrolides to treat a bacterial superinfection that has complicated COVID-19. So for mild COVID-19, antibiotics should be avoided, and for moderate COVID-19, antibiotics should not be used if there is no evidence of bacterial pneumonia. Standard empiric community-acquired pneumonia coverage per local guidelines typically adequate if patients do not have risk factors for Pseudomonas ureginosa or MRSA. For severe COVID-19, antibiotics can be considered as part of standard empiric sepsis coverage if shock is present. So next, under the assessment, we have the drug therapy problems. We conclude the wrong drug. So for next is for the plan. The plan was made to discharge the patient on self-quarantine for 14 days to limit transmission to others. And next is to discontinue the therapy since there is currently insufficient evidence to recommend treatment with macrolide antibiotics for COVID-19 alone or combined with hydroxychloroquine as well as the azithromycin outside a research. So here we presented another action plan to minimize the transmission of the COVID-19. For example, is to wear a face mask and cover your coughs and sneezes. Avoid sharing personal household items. Clean your hands often. Clean all high-touch surfaces every day. Monitor your symptoms and discontinuing home isolation. Patients with confirmed COVID-19 should remain under home isolation precautions until the risk of secondary transmission to others is thought to be low. And part of this plan, we have to get the vaccines for the COVID-19. And we presented also here for the Center for Drug Evaluation and Research Response to COVID-19. So 3 ways to treat COVID-19. Some of the drugs being developed to attack the disease and the SARS-CoV-2 virus that causes it. For block viral replication, we have the remdesivir. Disrupt the viral RNA synthesis. And another one is the EIDD2801 to disrupt the viral RNA synthesis also. Another one is the danoprevir or ritonavir to inhibit viral protease enzyme. And last is the RNA experimental compounds. It is to block the viral RNA synthesis. So to prevent entry into cells, we have the APN01 to decoy cell receptor and the multiple human antibody cocktail for antibodies neutralize virus. Another is the monoclonal antibody candidates for the antibodies neutralize virus also. And last is the TAK-888 to modified antibodies against virus. And to reduce hyperimmune response and acute respiratory distress, we have the Kevzara or sarilumab. It is for the antibodies block IL-6 immune cell signal. And for the Actemra or tocilizumab, it is for the antibodies block IL-6 immune cell signal also. And for the remestemcel L, it is for the stem cells modulate immune system. And last is for the Sézanne tofacitinib, it is to inhibit inflammatory cells. Under the evidence that we presented here is they include their drug action, company or laboratory, and the status of the drug.